there or just speak from here? From here. Okay. Okay. So I think we just speak from here.
Yeah. Stand up or just...
Oh no, this
So, yes, sir. Good morning, everyone. As the President of the Executive Committee of the European Commission of the foot and mouth for the control of foot and mouth disease, I would like to welcome you all here in this historic city of Alcala, and also it's wonderful to see how many professionals, many dedicated professionals gathered here to share our views and experience, and also how many join to us online. Today I would like to extend the Executive Committee's gratitude to Spain, our gratitude host, represented by Valentin Almanzar. I can't see him, but I hope he look at us. Spain has once again demonstrated its commitment to the EuFMD and the broader mission of controlling FMD and other transboundary diseases. This is not the first time when we are here in Spain, and Spain has generously opened its doors to us in 2022. Spain hosted the open session in Jerez. A lot of been achieved since then, so we are eager to reflect on our progress today in the opening session. After all, Alcalá de Henares is renowned for being the world's first planned university city, a model for education and knowledge sharing in Europe and Americas. What better place to come together, exchange ideas, and learn from one another. In closing, I wish you all fruitful and really inspiring days during this open session. Let's make the most of this opportunity to collaborate and move our mission forward. Thank you once again, and with that, I'm honored to pass the floor to the chair of the EuFMD Standing Technical Committee, Dr. Stéphan Zientara. Thank you.
Thank you, Lajos. Thank you very much. So I will read my paper because my English is not always very English. So as chair of the EuFMD Standing Technical Committee, it's my privilege on behalf of my colleagues who are Katerina Sterk from Switzerland, James Wood from UK, German Caceres Garrido from Spain, Sten Mortensen from Denmark, Giancarlo Ferrari from Italy. And by the way, I take this opportunity to thank them very much for the quality of the discussions and friendly atmosphere we have during all our meetings of the STC. So it's my privilege to extend a warm welcome to you all to the open session of our committee. The Standing Technical Committee plays a vital role in providing technical guidance to the EuFMD. By reviewing the latest research and offering expert scientific opinions, we help shape and guide the design of the EuFMD's work program, ensuring that our initiatives are grounded in the most up-to-date and effective scientific practices. One of our key responsibilities is to lead the organization and delivery of the open sessions, such as the one we are about to start today. These sessions are more than just a platform for information exchange. They are forums for generating innovative solutions, bringing together scientists, policymakers, industry, and international organizations. It is here that we recognize the immense value of networking and multi-sectoral discussions, which are crucial for addressing transboundary animal health issues. The Standing Technical Committee, through these open sessions, recognizes that science is the driving force behind the work of the Commission and its Secretariat. Science also serves as a foundation for the prevention and management policies against foot and mouth and similar transboundary disease implemented by our member nations. This year, we are joined by almost 202 participants from across the globe who have traveled far and wide to be with us for the next 3 days. This again demonstrates the importance and relevance of this platform in tackling the challenges we face. Our team this year will invite us all to explore the macroscopic impact of global megatrends on fast disease management, while emphasizing the importance of micro-learning strategies for effective risk mitigation. In our parallel sessions today, we'll dive into advances in epidemiological surveillance, virology, and the latest in vaccine innovations and selection. And tomorrow, we'll shift to diagnostics, control strategies, and modeling for emergency preparedness and response. While FMD remains a significant challenge and will be at the core of our discussions today, we also aim to transcend traditional boundaries, taking on a holistic approach to animal health. With that said, it is now my honor to officially declare the open session 24 open. So I think we can close. Just before concluding, on behalf of the STC and my colleagues, I would like to extend my warmest thanks to the EuFMD colleagues who made this Congress possible. So Nadia Rumi, Etienne Chauvin, Fabricio Rosso, Dónal, Sammin, and all the other colleagues I don't have time to mention, and I would ask them to excuse me. You can find their names on the EuFMD application. So now I'm giving the floor to Dr. Dónal Sammin, the Executive Secretary of EuFMD. Thank you, and I wish us all a productive and inspiring open session. Hasta pronto. Thank you.
Thank you, Stéphan. Good morning, all. I'm under starter's orders now because Stéphan has declared the session open. And anyway, I said a few words in the garden last night, so I won't go on. But just to say that the core objective of EuFMD is set out in the preamble to our Constitution. It says to promote national and international action with respect to preventive and control measures against foot and mouth disease in Europe. Well, science is absolutely critical to fulfilling that mandate. And whether that's the more traditional areas of interest on diagnostic tests and vaccines, or our newfound interests in digital tools, or in trying to better understand human motivation and behavior, but science will be the key to what helps us to make significant change and progress in controlling this disease and others. This year, we mark our 70th anniversary. And we have a proud track record, but we cannot rest on our laurels. Just like all of you in the world of science, you're only as good as your last gig, and you have to keep looking for what's next. You have to be agile, you have to be responsive, you have to move on. We are developing a long-term strategy, which we hope to share with you in due course, setting out where we want to be in 10 years' time, but you can rest assured that science will be a very significant part of that. We co-host this meeting with GFRA, the Global Foot and Mouth Disease Research Alliance, and we're delighted to do so. And Alejandra will speak after me on behalf of GFRA. And last but not least, I want to fill out what Stéphan said and mention the names. He thanked me, but I came here in a tie as front of house, having done practically nothing. The technical people who delivered on this, Etienne, Zorana, Kirill, and Valentina. We have our front of house people today. We have Sylvia, Rebecca, Michael on behalf of GFRA. We have Pilar helping there. We have people minding the home front, keeping the home fires burning like Flavia. And of course, we have Nadia, who has drawn it all together for us as on previous occasions. So that's it from me. Thank you all. Really looking forward to proceedings, but also the conversations we have on the margins about what next and how do we work together. I'll hand you over to Alejandra Capozzo, who is president of
CEO. Yeah. Well, this is just a few words to welcome all of you. We are really very excited in this special occasion that we are working together with the EuFMD. As you know, we are having a third day that is a forum dedicated for discussion, where we want to listen to all your voices. We want to listen to anything you have to say, and to discuss on very important topics on FMD research. So I'm not saying that much, just thank my colleagues from the GFRA, join us, and we're gonna still work together with the EuFMD. As you know, we are the two leading organizations working on FMD all over the world. We are a global organization, and you can find our members around. So thank you very much for this opportunity of working together. I look forward for a very fruitful discussion, and I will keep myself dressed in the EuFMD colors, as you can see. Thank you so much. Welcome.
So thank you very much again. And so we can open and continue to open this session number 1. And we will have a presentation on the global FMD update by Dónal King. So when Dónal is going to the floor, I will present Dónal, although it's not useful to present Dónal. But I will very rapidly read your CV, Dónal. So Dr. Dónal King heads the Vesicular Disease Reference Laboratory Group and the FAO World Reference Laboratory for Foot and Mouth, with a background in veterinary virology and immunology from the University of Leeds and University in California, Davis. Dr. King focuses on the evolution of positive-stranded genome viruses, particularly the foot and mouth disease virus. His team develops advanced methods for detecting and characterizing livestock disease agents, supporting the diagnostic work of the Purbright Institute and tracking emerging viral lineages that threaten the UK and Europe. And Dr. King is also an associate editor for the journal Virological Methods, collaborates on European diagnostic research projects, and contributes to molecular epidemiology using next-generation sequencing. He was the OR expert for foot and mouth disease and swine vesicular disease. So now the floor is yours for 20 minutes. Thank you, Dr.
Good morning, colleagues. Maybe I can have the first slide. No, that's not mine. Do you want me to go through? Perfect. Thank you very much. So thank you very much, Stéphan, for the kind words of introduction. And if you forgive me, just start with a short apology. So I only have a very short time today available to me in the presentation. So I'll go quite quickly through the main points. But of course, I will be here for 3 days. Many of my colleagues from the World Reference Laboratory are already here. So please do feel free to approach us during the times in the meeting for any clarification of any of the points I discuss. And some of the key issues that are raised in this presentation are actually covered in more detail in other presentations later on in the week. So just start with an introductory slide that I'm sure many of you are aware, but just to give you some context for the presentation, I think we all can see that FMD is very dynamic. The epidemiology of the disease is very dynamic and is defined by 6 circulating FMD serotypes that are unequally distributed in different parts of the world. And I say 6, if you look in the textbooks, you'll see 7 serotypes of FMD, but one of those serotypes, serotype C, has not been detected anywhere globally since 2004. And we now believe that that may be extinct. And again, there's another presentation on that topic later on today. So these viruses are maintained within 7 endemic pools. The locations of these pools are highlighted here on the slide. These are pools in Asia and in Africa, as well as Venezuela in South America. And this is what makes FMD perhaps a little bit different to other diseases which spread globally. In general terms, FMD stays in these local pools, and these local pools maintain specific strains over long periods of time. But of course, we also see increasingly perhaps evidence of viruses moving in unexpected ways between these pools. And when viruses move between the pools, this can have significant impact on the selection of vaccines, which can dramatically impact the ability of us to control the disease. So the presentation, of course, today will focus on some of these high-impact events where viruses are moving between the pools, but I don't want you to forget about the endemic circulation of FMD within the pools on a day-to-day basis. So within these long-distance movements. We see new risk pathways in Africa and Asia. And of course, again, often discussed within meetings such as this, we see that surveillance is often fragmentary and resources for diagnostics are often lacking. And again, that drives us perhaps to think of new technologies and new ways to collect information. But a key message here, of course, is as we are undertaking work to test samples, that it's really important that all of us contribute and share the information so that we can piece together evidence where it's collected at different locations and different sites. And of course, one of the mechanisms by which we share information is the reference laboratory network, which is the WOA FAO FMD reference laboratory network. Hopefully everybody in the room is familiar of this network. And so we have a website that explains more details of this network. And this was a network established in 2004 to bring together all of the reference laboratories that work on behalf of WOA and FAO for FMD. And the core activities of the network are to bring together and to share openly data regarding FMD outbreaks in different locations, to try to better understand the global epidemiology of the disease, and to use this information to inform in vaccine recommendations. We also undertake work to harmonize and improve the quality of tests, and also support regional initiatives such as those under the GFTABS umbrella to look at trying to improve FMD control in regional contexts. And of course, many of the leading laboratories are located in North America and Europe, if you like, the richer countries, which are usually the FMD-free countries. And so it's really important that this network also engages with reference laboratories in countries where FMD is endemic, and we're very pleased that a number of reference laboratories in Africa as well as Asia contribute to our network. So really, in case you fall asleep, the two key messages of this presentation are perhaps summarized by these two classic movies. So I'll tell you a little bit about viruses moving from India, and I'll tell you, and India and neighboring countries. And then the second part of the presentation will be discuss the increasing frequency of viruses moving out of Africa. So perhaps just to focus on one of the lineages, which is globally one of the most important FMD lineages, and this is a viral lineage which is called India 2001. And this is a viral lineage that we've all been monitoring for a number of years now, which emerged from pool 2. So this is India and the countries in the neighborhood, and has spread in an easterly direction and a westerly direction to quite significantly change the risk pathways in those locations. So not only is it an important viral lineage in pool 2, but it's becoming increasingly important, for example, in mainland Southeast Asia, and in that context has spread into new locations to cause FMD outbreaks, which has actually changed the WOA status for a number of countries. And a number of the publications and recent events are highlighted here on the slide. And again, just to remind you, this is the viral lineage that has spread into Indonesia to cause significant problems over recent years. It's the same viral lineage that's moved into Kazakhstan as well as into the Russian Federation to cause problems. So this is a very active lineage that is globally perhaps one of the most active of the FMD strains. And it's not the only virus that has moved recently from pool 2. We also saw previously serotype A viruses moving from pool 2 as well as serotype Asia 1. But the events associated with those virus escapes perhaps are diminishing over the last few years, and we see perhaps opportunities for new viruses to jump into those locations. Thinking about what might come next, and this is always something that we discuss quite widely within the reference laboratory networks, I think it's very clear that history tells us that viruses that circulate in pool 2 countries often become pandemic lineages that spread into other locations. And so we've been tracking the emergence of a new viral lineage, which is called SA 2018. And this is a lineage that was detected some time ago in India, is also detected in Nepal and Bangladesh, and spread into Sri Lanka quite quickly, and is now recognized to represent approximately 40 to 50% of the cases due to serotype O in India. So it's a very active lineage in India. And so you might ask, well, is this going to be the next virus that spreads more widely? And so indeed, we do already have some evidence that this is a lineage that may spread into other locations. So data collected both by the World Reference Laboratory and colleagues at ONSES have detected this in pool 3 countries, both in the Gulf states of the Middle East, as well as evidence last year of perhaps this lineage for the first time being detected in Iran. And the key message, of course, is that this virus lineage, although it's now emerging, it may have scope to spread more widely, particularly into mainland Southeast Asia, following the similar pathways that the previous incursions due to India 2001E followed. In terms of vaccine selection, there's good evidence, and again, important work of the network is to undertake vaccine matching testing, and we do believe that the existing vaccines will probably provide protection against this emerging lineage. But in terms of thinking about the European context, and for those of you outside of Europe, you have to forgive me, I'm also going to give a couple of slides which really here focus on risks to FMD-free countries in Europe. The situation in the European neighborhood really over the last couple of years since we last met in the open session has been very much dominated by the emergence of serotype SAT2. And again, this slide, I mean, you perhaps don't need to read all the detail, but the important message is there's a lot of ways that reference laboratories are now sharing information to put together pictures of the way that these viruses are coming and spreading within new locations. And this particular example relates to a virus lineage which is called topotype 14, which emerged in 2023 from East Africa and has spread quite quickly across a number of countries in the Gulf states of the Middle East. And in a number of those settings, this is the first time that this serotype has ever been detected. And of course, when a new serotype gets introduced into a region, there's opportunities for very rapid spread because there's no existing immunity in the herd population. The interesting point with this lineage, which I will touch on briefly towards the end of the presentation, is that this topotype has not been detected anywhere globally since 1991, and this raises some questions about perhaps where it has been since. The situation regarding topotype 14 has been very much mirrored by the spread of other serotypes, and they're highlighted in the box at the bottom of this slide, where other serotypes, again, probably with an origin in East Africa, have emerged to cause outbreaks in the Middle East. Thinking more widely about some other risks for the European neighborhood, we also very carefully monitoring the situation regarding serotype, particularly serotype O in North Africa. And sequence data provides evidence for very frequent emergence of new outbreaks, which probably originate either in West Africa or in East Africa to cause outbreaks in North Africa. And there are two risk pathways by which we think viruses might be being introduced into that location. And again, this is quite important because previously, FMD, for a long period of time, all the way from 1999 to 2013, there were no FMD outbreaks at all in North Africa. But since 2013, increasingly we see the emergence and incursions of new strains. And some of those events are listed here on the slide. And I suppose we now have perhaps a very active connection, epidemiological connection between West Africa and countries in North Africa. And you might ask questions, well, what has changed? And of course, a lot of focus there is in the building of new roads, these trans-Saharan roads that have been built, which perhaps facilitate now the movement of animals from FMD endemic countries into these new locations. So thinking about these patterns, I think it's quite interesting to say, well, can we again predict what might be coming next? And thinking about viruses that circulate in West Africa, for a number of years, we've been saying, well, the next virus that will probably follow this pathway is serotype SAT2, because that is also present in West African countries. And of course, earlier this year, we weren't particularly surprised that serotype SAT2 outbreaks had been reported in Algeria, but the genetic identity of these viruses was indeed very surprising. So the serotype SAT2 outbreaks that occurred in Algeria earlier in the year, and again, data very kindly provided from the reference laboratory in France. These viruses were characterized as topotype 5 within SAT2, not the normally present topotype 7 viruses. And again, this is due to a virus lineage that has not been detected anywhere since 1991. So you have 32 years without any cases due to this viral lineage. So in addition to the cases detected in North Africa, subsequently, ONCES have tested samples from Burkina Faso, and have also shown this virus present and in that country, and perhaps now it should focus our minds on the wider surveillance for this virus in other West African countries. So there's a real-time PCR, which will be useful tool for reference laboratories, and the reference laboratory at Perbra has undertaken recently quite a lot of vaccine matching, and some of the key points are summarized on this slide here, basically to say that the available SAT2 vaccines are probably quite well matched to this strain. But thinking about this sort of idea that viruses are coming unexpectedly, is there something that's occurred recently that we should be learning from? So I've already told you about the SAT2 topotype 5 example. Earlier I spoke about the topotype 14 example for SAT2, where viruses had not been detected for 31 years. We also had sequences recently for samples submitted from Uganda, and again, here, very unexpectedly, the most recent example that we could find in our databases was a virus from the 1970s, so there's actually a 46-year gap in the viruses that were detected in the domesticated species and the previous example of this viral lineage that we'd seen. And there was another example for serotype SAT2, topotype 4 this time in Kenya, where there was a 10-year gap. So why are these gaps existing? I mean, it might, of course, represent the fact that perhaps our surveillance is not very good, and perhaps the focus of the surveillance on certain species is missing key transmission events that are occurring in other species, and that may be small ruminants, and perhaps other species might be focusing our mind here. But I think the most obvious explanation is that these viruses are probably emerging from a wildlife reservoir, probably buffalo, and understanding properly what is circulating in the African buffalo populations may give us a flavor of the future of new viruses that will pose a threat to domesticated species. And of course, this reinforces the importance of trying to bring together the sparse data where we have it to try to understand these pathways. So I suppose thinking specifically about risks to Europe, the questions are, can we respond to an FMD outbreak in Europe? That's a big question that we always think about. But also, if we get a new serotype, can we extrapolate the knowledge that we have, which is largely from serotype O and perhaps a little bit of data from serotype A, to help us control FMD outbreaks to SAT viruses? So just to summarize some of the key events that I've discussed in the presentation, I've told you about this pandemic lineage, the India 2001 E lineage, which is causing a lot of problems in Asian countries. I've told you a little bit about the emergence of this new lineage, the SAT SA 2018 within serotype O, which is now spread for the first time beyond pool 2. Quite importantly, from a European context, we see the emergence of serotype SAT2 in pool 3 countries, in West Eurasian countries, and the Middle East countries. Associated with that, there's often questions about whether serotype SAT2 will move into other regions and other locations. And if you remember previously, we always discussed this idea that FMD viruses move in a westerly direction across pool 3. So their viral lineages usually emerge in countries such as Pakistan and Afghanistan, spread across Iran, and cause outbreaks in Turkey. Very rarely do they move from pool 3 to pool 2, or indeed that's what we thought previously. But recently we had some evidence of pool 3 viruses being detected in Bangladesh, which raises the possibility that actually viruses can spread from pool 3 to pool 2, which I think is quite an important observation. In Southern Africa, we have a number of new events which are quite important. We have the spread and emergence of serotype O in that location where previously serotype O was not found, and generally serotype O vaccines are not used to control the disease. And of course, in South Africa itself, they have lost their FMD-free status due to a number of ongoing outbreaks due to different serotypes over the last few years. And again, that highlights the challenges of regaining FMD-free status when you lose that through FMD outbreaks. Associated with the FMD cases In South Africa, we've also seen, again, for the first time, viruses moving into Mauritius, this time serotype SAT3 viruses. And again, raising this idea or reinforcing this idea that when FMD outbreaks emerge and then expand in one location, they can have impacts in other locations in an unexpected way. And of course, we see the situation in North Africa. But perhaps just to focus on the risks for EuFMD member states, we see a number of FMD lineages from Pool 3 countries, those endemic lineages that are still present, even though we focus a lot on exotic virus incursions, which I've spoken about. For the first time, colleagues at the SHAP Institute have reported serotype A cases in Turkey, which again is a relatively new event. And we also see, as I said in my presentation, FMD lineages in North Africa, not only serotype O, not only the SAT2 topotype 5 outbreaks, but also this very unusual event that was reported at the previous meeting where viruses had moved from South America into Egypt, and there's still some concerns that those viruses may still be present. And again, there's another presentation or another poster at this meeting that will describe those events. And I suppose when you look at this, you'd say the risks of FMD have not gone away. FMD is still present in the European neighborhood, and perhaps more FMD is present in the European neighborhood than has been previously found. And we see already the evidence of other viruses, such as PPR, moving into the European neighborhood. So I think all of us who work in FMD-free countries in Europe should keep that in mind when we think about the risks to Europe. So the last just couple of slides from me is just to highlight some places where you can get more information. Of course, very rapid presentation today. If you want to digest this information in a little bit more leisurely time, we have a new series of FMD dashboards called OpenFMD, which have been developed by the World Reference Laboratory in partnership with EuFMD. And these are a series of tools that we think could be useful for the FMD community. You can find FMD sequences, you have a platform that you can generate your own genotyping reports, you can retrieve sequence surveillance data, and you can also perform vaccine matching or vaccine selection analysis that can be tailored to your own requirements. And so this system has been in gestation for a number of years and finally went live in September this year on a dedicated web server at the Purbright Institute. And Antonello Donato, who's in the audience, provided a really good seminar highlighting the functionality of this system in a webinar in June. And so we plan to use this system within the World Reference Laboratory, and that will ensure the sustainability of the system. And we've been comparing the outputs with the existing processes to check that they're consistent. And also through funding from the UK government, but also funding, very generous funding from EuFMD, we plan to further develop these systems. And if you have any thoughts, if you have any comments about functionality that's missing or things that don't work very well, please do feel free to contact myself or Antonello or come and approach us during the meeting today. So just to wrap up, you can find a lot of information on the World Reference Laboratory network, the World Reference Laboratory website. All of the reports that we generate from a routine perspective are there. We also prepare, I'm sure, hopefully many of you will look at the quarterly report that we produce in partnership with the EuFMD, which summarizes some of the key events, as well as the annual report of the FMD Reference Laboratory Network. So I thank you for your attention and really thank the organizations that support the work of the World Reference Laboratory. Thank you.
Thank you, Don. Thank you very much. And thank you for the timing. So do you have any questions to Don? Yes, Nadia.
Don, quick question. It seems like we have learned a lot about identify the sequence, the migration of these viruses. Do we know anything about their characteristic in terms of the pathogenicity of these viruses? They are more effective in evolution or in transfer due to the fact that they are mild in their pathogenesis and therefore they could stay in nature longer? Or you see a more aggressive behavior on these viruses that are good spreader?
Yeah, thank you very much for the question. I think it's an important question, and I think the evidence regarding the emergence of serotype SAT2 in the Middle East would perhaps contradict what you've said. I mean, so they had very severe reports of clinical disease, clinical FMD in the affected animals, and even quite a number of deaths relating to FMD, not only in young animals, but in older animals. So I think this was also, if you remember, the similar pattern when SAT2 emerged for the first time in Egypt. They had similar reports of quite serious disease relating to FMD. So it's not that the disease can circulate without any clinical signs in a subclinical basis. It's very overt clinical disease, or that's certainly the reports that we heard from the field.
Yes, Michael.
Thank you, Dónal. A lot of very, very important points in there. What I picked up on in particular is this question of, is Europe prepared for these new viruses? Because, I mean, like you say, all the experience we have is O, a little bit of A, and then we're dealing with these SAT. And one thing that made me stop there, and I've seen it on other slides, is SAT2 in a pig in West Africa. That, to me, is absolutely crazy. Do you have any more information, any context on that?
I don't. I know Labib is in, maybe that's a question that'd be better asked to Labib. I don't know, Labib, whether you want to address that. But that's, I mean, in general, that's a question that we get asked a lot within the UK is will these new serotypes move into the wide range of species that we'd expect for serotype A? But please, yeah.
Thank you, Michael. No, we don't have any evidence of why these pigs have SAT2. And what was amazing, we received a lot of samples from Burkina Faso, only 2 samples from pigs, and what was the swabs and the epithelium, and we think that this is the same animal, and it's only this animal we found SAT2 fiber. So maybe, in my opinion, usually people sample cattle and mainly dairy cattle, and did not sample pigs. I don't know for which reason they sampled these pigs. So fortunately, we received the samples, or we find SAT2-5. So maybe a recommendation is we have to encourage countries to sample other species than dairy cattle.
Thank you. More questions to Don. I've got one to you, Don. Based on all the data you have shown, what is your opinion about the risk for Europe? Is it higher, or what do you think? Thank you, Don.
Well, I think it's a very simple question. I mean, I think if you look at threats into Europe, I think it's difficult to imagine any time over the last 20 years when there's been more complexity of viruses circulating in the European neighborhood. And like I tried to emphasize in the presentation, the emergence of new serotypes in new locations is a little bit different to viruses within existing serotypes that perhaps are covered to some degree by existing immunity. So I think the risks are very real. I was speaking briefly to Giancarlo earlier. You think about other viruses that have come recently into Europe, for example, PPR in Greece. That tells us that viruses can exploit these connections where they exist. And so I think we should all be happy that there's no FMD in Europe, and there's been no FMD in Europe for more than 10 years now. But I think the disease has not gone away, and I think that's perhaps a responsibility for all of us in the room to make sure we communicate that to our funders and make sure that we maintain the contingency and capacity to respond to these cases.
Thank you, Don. So thank you very much, and that's why this meeting is also very important. Thank you. So I think we can approach. So now we will shift to our next speaker, who is Dr. Madhur Dhingra, for FAO. So Madhur is the lead of the Animal Health Prevention, Preparedness and Response Cluster and head of the Emergency Prevention System for Animal Health, Impress Animal Health, at FAO. And so I think that everybody knows you. So you have the floor for 15 minutes. Thank you.
Thank you. Is this on? Okay. Okay. So good morning, everyone. I'm going to talk briefly about the PCP for FMD, talk a little bit about the history of the PCP and the reflections from implementing the PCP over the last years. And I'm very humbled to be standing here, because this work is not my own. It's been the work of so many people over the last decade. The members of the GFTAD's FMD working group, some past and present members, some of who are in this room, the PCP support officers, and many colleagues from FAO and WOA, as well as our member countries, the veterinary services from the member countries. So let's go back a little. It's year 2005, and rinderpest eradication is in sight. And I remember I was working in the veterinary services in India at that time. And many countries were asking the questions that, if we can do this for rinderpest, we can do it for FMD as well. But at the same time, the recent devastation that was caused by FMD outbreaks in 2001 was on everybody's mind. And for the endemic countries, it was very hard to imagine, where do we start from? Where do we start putting our efforts? For a country like India, I remember those discussions, that how do we approach this? And for those countries that wanted to safeguard their freedom from FMD, again, this was an important question. How do you improve FMD control at global level so that you are safeguarded and those risks don't reach your borders? And the question was, how do we start? So basically, the PCP-FMD, or the progressive control pathway, was really developed to bridge the gap between those countries that were endemic and those countries that were sort of aiming to bridge the gap between endemic status and freedom, to give a stepwise pathway to reach there. And it was developed jointly by FAO and EuFMD. And the principles were that it has clear steps outlined. And it was meant to be progressive, building on herd-level biosecurity measures, to determine the pace and the progress. I really can't see the screen. I'm struggling a bit. I think I need to move. Okay. And the principles were that it's supposed to be risk-based. Yeah. Identifying where the risks lie, identifying critical control points, and then targeting the resources there, because most countries, they've got limited resources. And it was based on a principle of monitoring, that because of these stages, the countries would develop certain ways to monitor their progress. And the activities could be tailored to different country contexts, different country risks. So it was first agreed to pilot this approach at the Shiraz meeting, where these 14 countries came together. And the principles were that these 14 countries would sort of share information amongst them, they would coordinate, and they would assess their progress along this pathway based on a peer review sort of methodology. Then in 2012, this PCP was really endorsed by WOA, then called OIE, and it became an official tool to support countries in their implementation of the FMD control work. So it became a core tool to support the global control strategy for FMD and to help countries to achieve their progress in becoming free by 2027. Not becoming free, but progressing. Yeah. Then what happened following the Shiraz meeting, which was sort of the first roadmap of 14 countries, there were several other roadmaps that were launched. And there was felt the need for a governance structure. And that governance structure was called as the Regional Advisory Group. So that governance structure consisted of countries from within those roadmaps who would then, review the progress of those countries. There was a sort of a knowledge sharing, peer review of progress that was established, and this governance mechanism was maintained over the years. A lot of enabling materials, trainings, they were developed to support the countries along the PCP, and all these came together in what is called as the PCP toolkit. And the self-assessment tool was provided to countries so that countries could assess their progress. And with the support of EuFMD, the PCP support officers were identified who helped countries to work along developing their national control plans. Now, coming to how successful has the PCP approach been? So currently, the PCP-FMD is being implemented by more than 75 countries. The goal was, when it was established, that most countries would progress to at least 2 stages. But in reality, there are very few countries, I think only 2 or 3 countries that have really progressed 2 stages or more. Most countries have progressed either by 1 stage, and some of them have even gone backwards. Yeah? But the reality is that the approach was felt as significantly important, significantly valuable, and the same approach was applied to many other diseases like PPR, like African animal trypanosomiasis, rabies. And it was also adapted to the management of complex issues, such as antimicrobial resistance, where the PMP for AMR was developed, the management of terrestrial animal biosecurity and aquaculture biosecurity, and FAO has these PMP TAB and PMP aquaculture biosecurity built on the PCP principles. The real challenge has been that global progress has been uneven, and as I said, many countries have not progressed. And again, most progress has been in those countries that see the value of tapping into export markets. And there, the incentive is really there to progress along these principles. And these countries, because they've seen the value, they've also received a lot of technical assistance, they've received investments that have gone into FMD control, and they've progressed to establishing either complete freedom or establishing free areas. Now, what have been the challenges to control FMD? And I'm not going to dwell too much on the technical challenges because, over these 3 days, a lot of those will be discussed. Disease-related challenges, challenges with vaccines, with vaccination, lack of biosecurity, lack of availability of vaccines. But I really want to focus on some of the institutional challenges. So I think the most important challenge that we've observed over the last years has been that of an enabling environment. FMD, how important is it to the regional bodies? How important is it to the countries? And that's what brings in investments. There have been competing priorities. COVID-19 happened, avian influenza happened, and resources keep getting diverted to other things. Information sharing, surveillance data sharing, all that is really hampered by not just lack of resources, but also because of the fear of barriers to either trade, or people are just not comfortable sharing data. How do we intensify the efforts to help countries to progress along the PCP? Now, one of the biggest challenges is that controlling FMD is seen as a public good. But for the vast majority of countries, who remain in stage 1 or 2, the benefits to controlling FMD really come from the fact that, there's benefit in production. or benefit to the livestock farmer. And for those countries, where export is not the goal or market access is not the goal, the control is really led by the private sector. But the vaccine availability, the regulations, all those policies are tailored for FMD control to be a public good. And there's a dichotomy there. So for those farmers or those private sector people who want to control FMD, the lack of availability of good quality vaccines is one of the biggest challenges, access to vaccines. And again, how do we build these public-private sector approaches where the private sector leads progress and control, but the public sector becomes an enabling environment to provide the necessary policies that are needed to control FMD. So further, I think the PCP-FMD is seen as something that is led at the national level. But change happens at the herd level or at the farmer level, yeah? And bottom-up approaches are very important. And this was a reflection that sort of FAO undertook about 2 to 3 years ago. And it was also our governing bodies asked us to develop a pathway that could really apply and support countries with a bottom-up approach to biosecurity management. And that's where the progressive management pathway for terrestrial animal biosecurity was born, because value chain actors need to be incentivized to strengthen biosecurity. And for those people where FMD control is not a priority for trade or market access, there needs to be a different incentive. So the progressive management pathway was identified. The framework was developed, and it's a framework to really co-create solutions for biosecurity management, for improving productivity, for improving the price of the products that come out of a particular value chain. So it's not a disease-specific pathway, but it's a sector-specific pathway, and it builds upon the principles of piloting certain co-created solutions for biosecurity management and then scaling them up. And then looking at the enabling environment around it, the legislations, the certification schemes. It could be even, AMR certifications driving biosecurity improvements. Now, another challenge has been, how do we build the evidence that investing in FMD control is important? One of the lessons has been that in those regions where the economic communities have really owned FMD control, they are the ones who've made progress, for example, in South America, in Europe. In the other regions where that ownership has been lacking, the progress has not been there. So how do we encourage these regional economic communities to own their progress? And again, I think it's important to link FMD control with the global agendas at the moment, whether it's the One Health agenda, whether it's the food security agenda, whether it's the climate mitigation agenda. And I think that evidence of how FMD control contributes to these agendas is a bit lacking. It's important for the regional economic communities or the countries or us as people who push FMD control forward to communicate to those people that we need, that FMD control is linked to your regional agendas. Then, in conclusion, I just want to say again that the PCP-FMD has been successful. There has been huge uptake by countries. It's considered as a very valuable tool, but there are investment constraints, there are technical constraints. There are opportunities going forward to integrate bottom-up approaches with the national level PCP-FMD approaches, and Dónal and I and a few others, we've been discussing how to do that. And bringing the private sector in to create solutions is really important. And then advocacy to bring in investments linking with the bigger agendas. Those are some of the biggest areas of opportunities to scale up FMD control. Thank you.
Madhur, you can stay if you have one or two questions to you. Do you have questions to Madhur for this complete review on PCP? And at the same time, I ask the panelists if they can come to the table. So no question. I've got one question to you, Madhur. If you consider the obstacles that the countries have to face, so you have politicness, willingness, and money on both. I don't know. What is for you the most important obstacle? What do you think?
I think the most important obstacle is really the value, understanding the value of controlling FMD. I don't think it's the money. I think for those countries where the value has been understood, investments have come. And I just want to give an example. You know, in Tanzania, where we started implementing the PMP biosecurity, the PMP tab, yeah. We had a small amount of money, but when the money was running out, it was the private sector players who came and said, we'll put our own money. It was the local governments who said, we'll put our own money to scale this up. And Tanzania is so happy with this that they want to apply this to the cattle sector for controlling FMD. Yeah. So I think it's important to start small, identify the benefits, get the buy-in, and the money comes.
Okay.
Yeah.
Thank you. You have a question, Dan?
Thank you, Madhur, for the presentation. A really good review, I think, of the PCP. I mean, I suppose a question that might be asked is there an assumption within the PCP that countries will always move towards FMD freedom? And should there be a reflection of perhaps more an equilibrium point for each, that's appropriate for countries with respect? You mentioned trade, for example, you mentioned trade opportunities. That has a massive influence on the desire of countries to become FMD free. And I suppose that's, as you reflect on the success of the PCP, it's trying to understand what the natural equilibrium point is for countries that are represented within the scheme.
Yeah, that's a very good question. And again, we had a FMD working group retreat a few months ago, and we did reflect on this. The challenge is that, you know, the PCP, it can take so long for a country to move from one stage to another. A country might be in PCP stage 1 for years. And then it becomes very difficult for them to measure progress or to see even if they are moving forward. Yeah, and so I think in that sense, breaking it down into smaller pieces, you know, within a stage 1, saying, okay, I'm in stage 1, but my key priority is to focus on 1, 2, or 3, and I just focus in one region, try to establish a compartment or maybe something like, and then scale it up slowly. That's the way to go, I think. And as I said, we've been discussing how to break it down into smaller bits for countries to make it more chewable.
Fabrizio?
Thank you, Madhur. No, I wonder whether the really success of the PCP is not really the control, because we cannot expect that a lot of countries progress in controlling the disease, but assessing and understanding what is the situation. I think that this is the foundation of the PCP. The first stages are understanding what are the serotypes circulating and what is the risk. And that probably allows countries that are interested in progressing, in taking the appropriate measure to progress in consideration of what are the risks for them and what are the serotype strains circulating in the region.
Yes. Is there a comment or a question?
Well, it's a comment on what you just said, but it is. I think might be wrong in saying, well, the PCP to assess the benefit of the PCP, counting the number of countries that are progressing. I think also there is a benefit in the first stages because those countries provide risk information that are relevant for the whole community.
Yes, but again, the community needs to perceive the benefit, understanding the risk and then what, and that then what takes so long that people lose interest. So I think that's the point I'm making, that we probably, it's a very good way to understand risk, to put in place surveillance programs, which is the thing that the public sector should do. But then what's the role of the private sector in that? And then the private sector needs to understand the benefits of controlling FMD. And then the PCP-FMD needs to tie in with something that brings the private sector into managing those risks. So I think that was the point I was trying to make.
Okay, thank you, Madhur. So I think we can applaud and thank Madhur very much. Thank you. So now we will open the panel discussion for 15 minutes. Yeah, you can see. So the panel discussion, the panelists are Madhur and Dónal. So of course, I don't need to present them. There will be also Santina Gradioli from IZS Brescia, Giancarlo Ferrari from previous IZS. Now Giancarlo is retired, but still very, very active. And David Bakali Kassimi from ANSES France. So thank you very much to be here. And so there are some questions that you can try to answer to with different points. So one point would be about the role of FMD Reference Lab and the spirit of collaboration and innovation in the FMD Reference Lab network. Third could be to highlight the successes and challenges and reflect on the future of global strategy. And then the last one would be the opportunities to integrate new technology in the global surveillance system of foot and mouth and other fast diseases. So that will be the three topics, and we'll try to discuss about this point. So I will perhaps begin with one question, which will be in particular for Dónal, Santina, and Labi, but of course, Giancarlo and Madhur, and you also, you can ask questions or give your opinion about that, of course. So from the perspective of the reference laboratories, what, to your opinion, is the key challenges currently hindering global FMD surveillance, and what innovative solution or strategic options can be pursued to strengthen the diagnostic capacities, data sharing, and international collaboration within the FAO or RefLab network to improve monitoring FMD. So perhaps I will first begin with Dónal or Labi, I don't know. Labi first? Okay.
Thank you, Stéphan, and thank you, Dónal.
You have changed the plan.
Okay, so in my opinion, from the lab perspective, there is many challenges that we faced at this moment. The first one is the sampling, because we see that there is a lack of sampling, as Dónal showed in his presentation. We suddenly see new lineages that appear after 30 years, so this is really reflect the lack of sampling. This is the first thing. The second thing is the shipment of samples. Sometimes people collect samples, but the shipment of samples costs a lot, and this is really one of the difficulty to receive samples from countries that to look for viruses and to characterize viruses. I know that there is many protocols that are now under development to reduce the cost of shipment that include inactivation of the virus before shipment. So this is another thing. Another challenge that maybe we have to continue to work on is to improve the laboratory capacities in the countries and to transfer technologies to the countries to let the country be able to detect and characterize the virus in their country. And this is, I think, the major challenge that we have for the control of the disease.
Thank you. Labib, Don, do you want to?
In addition to those mentioned by Labib, in my opinion, also the training that the reference labs could offer to the people are a very useful tool to improve not only the preparedness of the labs, the performance diagnostic, but also to try to connect the scientists from different countries, from different labs, and to establish a strong relationship that could be very useful in case of emergency. In particular, after the COVID, also the online meeting is frequently used, and these new tools could help to organize in the very short time a meeting to support, to help to interpret the results, to give a suggestion how to manage the disease in the field. So this is the role also of the reference lab.
Yeah, I mean, I think I completely echo the points from my reference laboratory colleagues. In particular, I think the issue relating to costs of samples that are received by the reference laboratories, and as not just the cost, but also the logistics requirements of ensuring that samples are safely packaged, safely shipped, and that is properly documented. I mean, this is becoming a real headache for international reference laboratories, which is incurring a huge amount of costs. And it's something that I think really drives us, as Labib says, is to think about whether all of the testing is needed to be done at international reference laboratories or perhaps with some of the new technologies. And we will hear, I'm sure, over the next few days a lot more about these new technologies, whether some of those new technologies can be deployed into local settings, and that data, communication of data, comes at no cost. And I suppose that raises the other issue for me, which is transparency. And so within our reference laboratory network, we're very honored, I think, to have very good collaboration and good spirit of sharing of information. But I think it's fair to say that that's not universal. And I think still we continue to see FMD cases occurring in certain locations where national governments are very reluctant to report those outbreaks internationally. And I think that's a missing part of the information that we have. And perhaps that's I know it's a discussion with WOA, perhaps, as well as colleagues at FAO, to try to facilitate a better way of sharing information between us. Because if we only have small pieces of information, then there's a danger that we completely misinterpret what is occurring from a global perspective in terms of risks. So I suppose it's, I think those are the challenges for the network. And like I said in the presentation, it's trying to piece together the little pieces of data that we have. We don't by any means sample all of the animals. There are many animals that are infected with FMD, and we're only taking a tiny tip of the iceberg of samples that are received to reference laboratories and trying to use that information in a productive way.
Thank you, Don. So does someone in the audience has a comment, a remark, a criticism, or something to say about this point? Yes? Yes. The lady first, Mikhail, if you agree.
I think that, they are very important points that were raised, and I think one, at least in my limited experience, but analyzing this from surveillance in Africa, comes from the education that you could provide to those local to understand the impact, not only the disease, but quite often, in order to do a very productive surveillance, you have to work with the district veterinarian, with locals in different regions, where you could actually access even to difficult areas where there are political issues or safety issues or geographical issues. So working with those is important, but giving the education, I think that is critical. So the local people understand that you are not invading their space and taking things from their animals, that they are a benefit. So the education that come along with these programs, I think, is important. And also for the countries that are collaborating on this surveillance is to see the value and see that they are gaining a better quality on their performance in their laboratories. So I think what Don was saying, improving the local testing, and people are going to have pride of being contributors on a larger, goal. And I think that's is what I'm trying to stress or make a point that that education and engagement is very, very key. So to have a positive response for those in the endemic countries willing to contribute. That's my experience.
Thank you. Mikael, and after short questions, sorry, because you have to follow the time.
Yes, thank you. Don has mentioned this unevenness in access to data and samples in different regions. How much distortion is caused by this, and how much does that impact the quality of conclusions that you draw from the samples you get?
I don't think there's an easy answer to that question. I mean, I think we tell a story, so I put together a narrative of what I think is the truth, but I don't know whether it is completely the truth.
Yes, yeah, thank you. Yeah. Oh,
Good morning, thank you. So, starting from what Dónal talked about, we're beginning to see existence of co-infections in Nigeria, where you have herds of cattle being suspected of having FMD, but at the end of the day, you also see them coexisting with situations of contagious bovine pleuropneumonia, CBPP. And this is beginning to call for serious issues of, say, you have outbreaks of CBPP. Could there be possibility of co-circulation of FMD in such herds? Coming down to what Madhur said, my concerns are very simple. In Africa, especially in West Africa, Sub-Saharan Africa, you have unstable regions due to humanitarian crisis, conflicts, terrorism. Nigeria, to be precise, the northern part of the country holds over 80% of our livestock population. But this same region is being currently faced with serious conflict issues. Hence, underreporting of FMD outbreaks has been a major challenge. How then can the FAO help in terms of its PCF or PCP in engaging communities affected by conflicts or presently undergoing humanitarian crisis in simple measures for disease reporting that might help FAO? And again for Don, what measures can we put in place in crisis-prone zone for the rapid field detection of FMD that will aid FMD global surveillance? Thank you.
Thank you. That's a very good question. And, I think we have focused a lot on getting information. But I think in order to build the trust with communities, it's important to get information to them first, yeah? And to provide them with good quality services. And now, mobile technology is everywhere. So getting information to the farmers on risks. There's an FMD outbreak in the neighboring village. Protect your animals by doing X, Y, and Z, yeah? Or getting information to the community health worker or animal health worker. In many of these places, there are no last mile veterinary services available. They are provided by community health workers sometimes. So engaging with village leaders, with community leaders, I think that's an important way to enhance surveillance, because if they trust you, they will give you information. If they don't trust you, you are just seen as coming and taking something from them. So we We are trying to pilot some of those approaches, you know, in a few countries. But again, it boils down to good quality knowledge and information being provided to the service provider, to the producers, to help them to safeguard their livestock. And FMD is just one part of that puzzle.
Thank you. Well, very, very short question, because we have to go to the second, and we have 2 minutes.
Just another quick question on the PCP. If you look to the last two stages, it says free with vaccination and free without vaccination. And that sometimes suggests to some people and even to governments that the logical next step, once you're free with vaccination, is free without vaccination and stopping vaccination. And I sometimes wonder whether that in some cases is a wise decision, because it also takes away the insurance policy of the vaccination. And wouldn't it be, and let's say, should we not put more clarity that maybe both could be considered equal, and that you don't necessarily, depending on the case, have to make that next step?
Yeah, I think this is a question that needs to be discussed with WOA. You know, are the two equal? Yeah, I don't think there's an easy answer to this, but I think this is something that can be discussed with WOA.
Thank you, Madhur. And just, we have 1 or 2 minutes, so I would like to have the opinion of Giancarlo on the implementation of PCP. Giancarlo, if you can.
No, just to make a comment also on what has been asked now. In fact, the last revision of the PCP, the freedom with vaccination and without vaccination is a domain which belongs to WOA. So the PCP has been revised in the sense that the first, let's say, 3 stages of the PCP are within the GFRA framework, and then once a country decides to have as an ultimate goal eradication, following with vaccination, assume first, and then without vaccination, that's enter into another domain. I think there is some important issues related to the PCP that I just wanted to mention, and I will make reference to what Madhur has been saying. Well, if you think about, you know, the moving from stage 1 to stage 2 means that you are introducing a new element into the progressive pathway, and that element is action. Because in stage 1, you accept the idea of, let's say, studying the situation, having an understanding of the epidemiology of foot-and-mouth disease, sometimes even having an understanding of which serotypes and genotypes are circulating, which are obviously essential to make the best selection of the vaccine that you are possibly going to use. But then, when you are trying to move, when you are translating this into action, that's where you start to move into stage 2. And that's where you might face a lot of issues because of lack of resources, because FMD in many situations is not a priority. And many farmers, they can cope with FMD. And there are competing issues for these people. The second point that I want to mention is, and obviously at that stage, you might need that there is some public-private partnership that is established in order to take some action. But there are examples where this public-private partnership has been established and worked. In situations where you have, this is my experience, where you have farming systems which are pivotal to maintain FMD virus over time, perpetually, forever, there are examples where the private sector said, well, we can pay, we can contribute for the vaccine, but they asked to the public sector, make sure that what we are using is the correct vaccine, contains the correct serotype, the correct genotype. Now, this information is available with the public sector usually, so that's where you can develop such a relationship. And the final point, and then I close, moving to stage 3, it's, and then I go to what Don was saying before. It's not necessary. A country can remain in stage 2 forever. Moving to stage 3, meaning that there is, and usually it is associated with a strong political will, that the countries want to access external markets. And there are examples in my experience where this has happened. The president of a country said, oh, we are a big country, we have to export our meat, we have to export our animals. And then he realized that there was a problem of FMD, of brucellosis, and other several problems. But nevertheless, this was a sort of such a strong political will that the country succeeded in reaching FMD freedom. So this is to say that, recalling what Madhur was saying, the old story started, when we were approaching rinderpest eradication, and there was no framework for FMD activities to be implemented, because either a country was infected or was free. And by the definition of the WOA, if you are not officially free, you are automatically infected.
Okay, so thank you very much, Giancarlo. I'm really sorry, but we are out of time, and if I don't respect the time, Etienne will kill me. And so thank you very much. I think we can thank the panelists, so thank you very much. Next time we will have longer panel discussion in future. And now it's my pleasure to give the floor to Tsiatko and Nick for pox viruses. So thank you very much again.
Then thank you very much, Stéphan, and good morning to everybody. It is my great pleasure to introduce the next speaker, Nick Derek. Nick is a bioengineer and obtained his PhD in veterinary medicine in 2007 at Ghent University, Belgium. He started working at the Belgian One Health Institute, Cienzano, the former Coda Serva, in 2010. Since 2021, he became head of the Service of Exotic and Vector-Borne Diseases. Among others, his lab hosts the European Reference Laboratory for Capozzo viruses and is appointed as the WOA Reference Laboratory for lumpy skin disease and for sheeppox and goatpox. He is member of the Scientific Committee of the Belgian Food Safety Agency and is visiting professor at the Ghent University. Nick will introduce to sheeppox and goatpox and lessons learned from the recent European outbreaks. Over to you, Nick.
Thank you very much, Sviatko, for the nice introduction. I'll just wait a second for a pointer. That will be helpful for my presentation. So, as many of you will be aware, Europe has experienced several outbreaks of sheeppox the last couple of years. So, that will be the topic of my talk today. So, I probably could have skipped this first slide, definitely for an audience who is familiar with FMD, but I just wanted to say that also sheeppox virus is a WOA notifiable disease, and it's classified as a category A disease within the European Animal Health Law. So this means when it's introduced in your country, in Europe, you should do all the necessary to eradicate it as soon as possible. So an infection with sheeppox will cause a lot of direct economic losses due to animal mortality, veterinary costs, and so on. But I think the most important costs come from the indirect economic losses due to restriction in animal movements, trade restrictions, and so on. But there is, however, a big discrepancy between FMD and sheeppox virus. Sheeppox virus is really namely a neglected disease. When I looked in PubMed a month ago, I could only find around 130 papers on sheeppox and goatpox virus, while this is more than 6,000 for FMD. So this will make that you will not see a lot of fundamental virological data in the presentation, but I will focus mostly on epidemiological facts. So this map shows where you can find sheeppox and goatpox. So it's endemically present in a large part of Africa. It's present in the Middle East and Turkey, and it's also reported from many countries in Asia. From Europe, there is not so a lot of information, so it seems to have been present in the past, but it was eradicated during the previous century. There are some records that the last outbreak in Spain was in 1968. In Italy, there have been an outbreak in 1983, and in Greece and Bulgaria, you will see over the past decades, there have been outbreaks from time to time. Similar information can be found when you look in the WAHIS database. So the colors are not so good, but if you look on this map, it shows based on different colors when countries the last time reported an outbreak of sheeppox and goatpox. And you see over the last 5 years, most countries from what is considered the endemic region have reported cases. And in 24, we have had outbreaks in Mongolia, in Georgia, in Libya, and of course also in Greece and Bulgaria. So that will be the main topic of my talk today. And I will start about 2 years ago, when in September 2002, Spain reported an outbreak of sheeppox virus, which was more than 50 years after the previous outbreak. And so that outbreak went on for several months. It was only eradicated in May 2023, and in total 30 herds got infected. A little bit later in 2023, in September, Bulgaria notified an outbreak close to the border with Turkey, but this was contained very quickly, and there was just one outbreak. Then later in the year, Greece first notified an outbreak in the island of Lesbos, which was also very quickly contained. But in December, they notified outbreaks in the Greek mainland, and that took a little bit longer to eradicate the virus because it kept on spreading till March of this year. And in total, there were 9 outbreaks. So we had hoped that that was the end. It was not the case, because this summer in August, Greece reported new outbreaks, and this time really in the far eastern part of the country, close to the Turkish border. And this outbreak is still going on. By now, there have been reported already more than 120 infected herds, and you can see that the virus has been spreading to the west. And interestingly, or not, last week, there was also reported outbreaks in the central part of the country and even in the southern part of the country. So we will have to see how this evolves in the coming weeks. And then lastly, a little bit after the outbreak in Greece was notified, also Bulgaria notified a new outbreak, this time a little bit further away from the Turkish border. It was also quickly contained, but 1 month after the first outbreak, last 1 or 2 weeks ago, they reported some additional cases. So also there, the outbreak is still ongoing. So for the rest of my presentation, I will focus a little bit more on the epidemiological data from those outbreaks. But before doing so, I think it's important that I tell you a little bit more about the transmission pathways of sheeppox virus, because this largely determines how the virus spreads. So first, very important transmission route is the direct transmission, because animals that get infected excrete a lot of virus. So animals get a respiratory disease, so they can excrete virus in aerosols, which can cause new infections. But there is also a lot of virus present in the saliva, in nasal discharge, also in feces. So this all can make that new infections can occur. So during an infection with sheeppox virus, there is a lot of virus to be produced. And what's very important to keep in mind for sheeppox virus, but that's the same for all copypox viruses, is that these viruses are very persistent when they are present in biological matrices. There is some information, for example, that the virus remain infectious in blood for up to a month, 2 months in nasal discharge, and then in the scabs, in scabs, where there is a lot of virus present, the virus can remain infectious for up to 6 months. So even if scabs then detach from the animal and get into infected pens or even in pastures, the infectious virus remained present for a long time. So this really gives rise to the high possibility of having indirect transmission. And this can be by many routes. It can be by workers that visit the farms, like sheep shearers, veterinarians, and so on. They can transmit the virus from farm to farm. The virus can stick on their clothes, on the boot, but also on equipment that's shared by farms. You will have disease that is transmitted by trucks that go from farm to farm, and then you have to think of milking trucks, feeding trucks, and so on. So the virus can be in the environment, it's on wool, on hides. And something that's also important to mention is that there is some data in literature that, for example, stable flies can also transmit sheeppox virus, but there it's important to emphasize that sheeppox, contrary to lumpy skin disease virus and other capripox virus, is not considered as a vector-borne disease. So these transmission routes are closely related to the control measures that you need to take if you want to eradicate the virus. So because the control measures will really aim to stop direct and indirect transmission. So there is nothing special. Those control measures are the same as those that you would take for other transboundary animal diseases. So you will start by stamping out the animals that infected herds, followed by a thorough cleaning and disinfection. You will implement movement restrictions. So you will implement protection and surveillance zone. And very important, you will quickly install active surveillance to quickly detect additional herds that are infected. And also you will do a lot of epidemiological investigations to see where the virus has spread since its introduction. And then also very important, because there is such a high chance of indirect transmission, it's very important to have a good biosecurity at all premises where you can have the virus, so a good biosecurity at the farm, but also at milk plants, at slaughterhouses and so on. And there you have to consider all people that go between those establishments. And then the experience from Spain has also shown that it's important to be aware of the environmental persistence, and that it's important to prohibit common grazing. And then lastly, a last control option that you have is doing vaccination. But here I will already say that the previous outbreaks in Europe have shown that you can eradicate sheeppox virus without proceeding to vaccination. But I will come back to that at the end of the presentation. So now I will go a little bit more in depth in some of those control measures, and I will try to link them to the European outbreak and see if there are some lessons that can be learned. So the first thing that's important after you have an outbreak is that you want to get a feeling on how the virus will behave in your animal and within your herd once it gets introduced. So generally speaking, you will first have an incubation period followed by the clinical disease, which will start off with some non-specific symptoms, which go from fever, depression, and also quite quickly you will see things like conjunctivitis, rhinitis, nasal discharge, and so on. And then you will also quite quickly see the specific symptoms for sheeppox virus, and these will be overlapping with the non-specific symptoms. So the specific symptoms, that goes to the formation of macules and papules, which will further develop to scabs, and you will not only have lesions at the surface of your animals, but also in the internal organs, like the respiratory system, but also the gastrointestinal system. And then probably in the end, a part of your animals will die. What's important here to remember for the rest of the talk is that from the moment that you have the non-specific symptoms where there is excretion of the virus, you have the chance of onward transmission. So you have noticed that I was rather vague about how long is the incubation period, which clinical disease will exactly appear, how high will be the mortality. That's just because there are quite some factors that determine the outcome of the infection. So we know there is difference in virulence between strains. It will depend on the inoculation dose, and it will also depend on the breed of animals. And in that perspective, if you would have looked in literature, you would have found that probably European breeds are very susceptible to an infection with sheeppox virus, and you would expect a higher mortality. But that was contrary to what has been reported by the colleagues from Spain and now also by the colleagues from Greece, where they really describe that the disease that they see, it's rather mild and it progresses quite slowly. So to get a better feeling on this virulence of the strain, we just finished an experimental infection study in our BSL-3 stables with the strain from the Spanish outbreak. So we did an infection study in sheep via the intranasal route of inoculation with a low virus dose. And in that experiment, we could find a rather short incubation period of around 5 days. And then quickly you saw the non-specific clinical symptoms going from fever, depression. We saw the nasal discharge in more or less severe forms. You could have conjunctivitis, you would see lesions in the mouth. And then already after 8 days post-infection, you also started to see the specific symptoms. So it's the development of the macules and the papules, and we know in the meanwhile that the region under the tail is one of the first areas where you can see the proof of an infection with sheeppox. But then afterwards you also see those papules on the other parts of the body. Here it's on the snout, you will find it on the tongue, And you will also see it on the limbs and other parts where there is not much wool. So all typical symptoms are there, but what became apparent during our studies is that in most animals, the disease didn't really progress much further. We never observed the formation of scabs. And I have to say that in 5 of the 6 animals that we inoculated in this way, they even start to get better after 12 days post-infection. Only 1 of the animals needed to be euthanized, and that's really because it was severely depressed and had a high fever. But we didn't see the high mortality. So that seems to be in line with what was reported from outbreaks on the field. Some from the field data, there is one publication from the Spanish colleagues. They estimated based on what they observed in the field that there was an incubation period of about 2 weeks. So that could be maybe due to the viral dose that we inoculated, which is higher than what animals receive in the field. Many of the animals were only limited symptoms, but in some animals they also saw the typical symptoms as the lesions under the tail, lesions on the head, on the body, and in some cases in the field, the papules developed into scabs, and you also see in some animals the really scars on the hides. But I think as a take-home message from this, it shows that if you have an outbreak of sheeppox virus, you should not necessarily expect a huge number of severely sick animals or a huge mortality. So it can be mild as well. So as I already mentioned it in the previous slide, so once you see here this specific symptoms, the virus is being shed and you can have transmission to new animals. So it's very important to detect an outbreak as soon as possible. So in that perspective, I can say that there are quite good diagnostic tools to detect an outbreak. I will not go into detail, but from the proficiency test that we organize as a European reference lab, we know that those tests are generally well implemented, and that's not really the limiting factor to detect an outbreak. What can be more difficult is that in the countries where we have now seen the outbreaks, is that there are several endemic diseases which give similar signs in the beginning of the infection. For example, an infection with blue tongue virus or with ectema, a parapox virus, give highly similar lesions as you will see with an outbreak of sheeppox. So in these countries, people will first think that it's probably an infection with these diseases, will be tested for that, so you will lose quite some time before they think that's probably a transboundary animal disease could be there. And it could be different transboundary animal diseases. Also, PPR gives similar symptoms in the early stages. Even FMD could give similar symptoms, and sheeppox virus. So there should be really a high awareness about all these diseases if you want to have an early detection. The nice thing, between brackets, of the recent outbreak is that we can use them to have a look how good we actually are in early detection and detection of the index case. So that's what's shown in this table. So first of all, this was the outbreak that was reported in Spain. And here you see, for the first outbreak, around 10% of the animals in the herd were found dead. So it should not be a big surprise. It was the first outbreak in 50 years in Spain, so people didn't really think very quickly about an outbreak of sheeppox. But this really makes that the virus was present on the farm for a long time and probably had the chance to spread to further farms. So you can also, that's also logical that afterwards many secondary outbreaks were seen. The story was a bit different from the outbreak in Bulgaria last year and also the outbreak on Lesbos. There, the infected herds were detected very early after infection. Only a limited number with clinical signs were present on those farms, so those outbreaks could be contained very quickly without many secondary cases. This was again different from the outbreaks in mainland Greece of last year and also from the outbreak of this year, because in one of the outbreaks you already had dead animals of the farm, and also in the other outbreak there were plenty of diseased animals before the disease was notified. So this makes here that there was quite a lot of virus already circulating and probably has spread to other farms, and that's indeed seen with the outbreaks that had many secondary infections and for the moment are still ongoing. And then lastly, we have the outbreaks of sheeppox in Bulgaria of this year. And there, again, they were very quick in detecting the index case with only a limited number of animals which were clinically diseased. So that outbreak was stamped out very quickly. And it seemed to be resolved. But as I said in the beginning, there are now 3 other cases, so we will need to see how this goes. But in general, I think these data show what everybody of us feels, what we know, is that if you do a really early detection, you have a high chance to eradicate the virus without having many secondary infections. So to detect those first index cases, we really rely on a good passive surveillance. So this means that there should be a high awareness about the disease for all stakeholders. So farmers should be aware, private veterinarians, official veterinarians, but also official veterinary services. And to get this high awareness, it's important that there are continuous information campaigns. You need continuous training of your veterinary staff, and also contingency plans should be there. So this is not specific for sheeppox virus, this is for all transboundary animal diseases, but I think it's a very important take-home message. Okay, once a country has detected the first case, one of the next steps it will do is in the implementation of an active surveillance. And seeing the clinical signs, the most surveillance that's implemented is first the clinical surveillance. And in theory, it's quite easy. It will be official veterinarians that will visit farms in the protection zone and the restriction zone, and they will try to see if there are animals infected. That's in theory. In practice, it can be a little bit more difficult because there can be a lot of sheep on those farms. We have farms with hundreds, even thousands of sheep. And as I showed, what you are looking for is not so clear. Sometimes you're just looking for some nasal discharge or some first signs of papules under the tail. So despite that it seems difficult, it seems that our veterinarians are very good at it. So these are some data from the Spanish outbreak, where you can see how many mortality there was on the farms and how many clinically diseased animals, and this for all the different outbreaks in the region of Andalusia. So I already showed for the index case that there was a late reporting because you had 30 dead animals on the farm, but afterwards, on most of the farms, no dead animals were present at the moment that it was notified, and even only a very limited number of clinically affected animals were present. So sometimes they were able to detect the presence of the disease based on 1 or 2 diseased clinical animals. So if you are in this case, this means that you can stop the outbreak very soon and that you will probably have no onwards transmission. Something similar can be seen in the ongoing outbreak from Greece. So here I show some data from the ATIS database, and it's just some representative farms, where you can see something highly similar. So as I said, for the index case, there was a high number of diseased animals on the first farm before it was notified, so it was clear that the virus has spread from there. But during the clinical surveillance, you see that, again, people do a very good job. On most of the farms, there is no mortality to be seen, and also a limited number of clinically diseased animals are there. So clinical surveillance seems to work fine, except for Greece. There are some cases where at least there were a few dead animals on the farms, or there were a few farms with a high percentage of diseased animals, so probably those cause that our current outbreak is ongoing and is difficult to contain. So the current outbreak in Greece also allows me to show you one other thing that we sometimes see for sheeppox virus, and that's the virus is capable to appear in new areas or in areas where it has been eradicated before without outbreaks in between. So it seems to be able to jump. We don't know how it comes, but that's what we saw last week, and so we will need to see how that evolves over the coming weeks. And what's also interesting, if you have an outbreak in a new region, often the detection is not so early, and we see the same in Greece. Here on both outbreaks last week, dead animals were present, so probably virus has been there for quite some time, so we will have to see what it gives. Okay, with my previous slides, I think I have shown that clinical surveillance can be a good tool to do early detection, but of course we can also make use of laboratory surveillance. And that's something where Spain did a great job during the previous outbreak. So first, in the beginning of the outbreak, they relied on clinical surveillance, and they detected several infected herds, but they still had the feeling that they were running behind the facts, and they wanted to see if it would not help to implement laboratory surveillance to have an even earlier detection. So what they first did, they determined which would be the ideal matrix to do that laboratory surveillance. So they compared blood samples and oral swab samples from a number of infected sheep, and they saw that Oral swabs are a very good matrix to do an early detection of sheeppox virus, better than blood. So they decided to do laboratory surveillance with swabs. And they also showed that it's possible to pool the swabs without having a great loss in sensitivity. So they went on in this way. And in this manner, they screened 41,000 swabs during a number of months. And it really showed that implementing also laboratory surveillance can help you to detect early outbreaks. Because by using this approach, they had detected 2 farms where sheeppox was present before any clinical signs could be observed. Of course, when they got the results from the laboratory, they went back to the farms, and at that stage, a couple of days later, both farms also showed to have clinical signs among the animals, so they just had gained a few days. So you can imagine that testing 41,000 swabs cost a lot of money, and also cost a lot of time, so therefore Spain in the end decided that the benefits were not great enough, and they went back to the clinical surveillance. I have just a couple of slides more. So I think this is also an interesting thing to share with you, because all of you will know, in case of an outbreak, the first questions that you will get is, where is this virus coming from and how was it introduced? And nowadays, we will quickly look to molecular epidemiology for that. So you will look at the sequence of the strain, and you will see if that will help you to determine where it's coming from. Well, that has shown to work very well for several RNA viruses, which have a high genetic variability, but it does not really work for Capripox viruses, because these are double-stranded DNA viruses, very large viruses, but mostly they are very genetically stable. So there is a little variation about its genome, so it has already been shown that it's not useful to do molecular outbreak tracing. However, as a ref lab, we think that it's interesting to do whole genome sequencing of those outbreak strains, because I think if we have information from many regions of the strain that circulate, it could be helpful to point out where the virus is coming from. So therefore, we have been collaborating with all of the countries which had recently outbreaks, and we were able to determine the whole genome sequence, and we got some interesting results from that. So it shows that the strains which were circulating in Greece, in Spain, in Bulgaria, are very linked closely together. There is very little sequence variation among them, and they cluster within a clade of A2 strains, which also has strains from Turkey and Egypt. So it just allows us to tell probably that the virus is coming from Northern Africa or the Middle East. The lack of more sequences in the database make that we cannot pinpoint the origin more clearly. Then we also sequenced the outbreak from Georgia, and there, probably logically, it was most closely linked to a strain from Kazakhstan, so that also makes sense. And then my last slides are about vaccination. So my presentation focused mostly on the European context, and as I already said, we have shown that if you properly implement the control measures, it's possible to eradicate the virus without vaccination. But on the good end, vaccines are available, and definitely for endemic countries, those can be very useful to minimize the impact of the disease. So most of the vaccines that are available are live attenuated vaccines. They are rather cheap, which is a good thing. And they also have shown to have good efficacy. We have tested some in our animal stables, where you see that the infected control animals clearly develop a strong clinical disease, while the vaccinated animals are very much protected. Immunity is also very long-lasting, but the downside is that those vaccines are no DIVA vaccines. You cannot use them in a preventive way because you will lose your free status, and from time to time you will see some side effects. Most side effects are the induction of a fever between day 4 and 8 after vaccination, and in some cases you will see a swelling of the inoculation site, which can last quite long and sometimes even evolve to necrosis. But that depends on the vaccine, and it can also depend on different batches. So that's my final slide. So I hope I could convince you that many European countries, if not all, are really at risk for a potential introduction of sheeppox or goatpox due to the movement of animals or humans. For example, here you can see the migratory routes of refugees from the endemic region into Europe. So this really shows that southern European countries are at risk. But you should also consider that the disease can be imported by animal products. Here you see a map from an EFSA report about the importation of hides. And so we know that hides from infected animals can still contain the virus, which can remain infectious for a long time. So this also could be a potential introduction route in your country. So with that, I think it's very important to have to be prepared for a potential emergency, have a good awareness among all stakeholders, make sure that you have the laboratory capacity and the contingency plans in place. And if that's the case, I think this could help to have a structured outbreak response. And then I end off by thanking my team at Zientara in Brussels for all the great work that they do. I'm happy that several of them are over here today, and they also have several presentations, so please check them out. And then I want to thank the Commission for the funding, and definitely also the national RAF labs and the veterinary services of the recent countries with outbreaks for willing to collaborate with us. Thank you very much.
Thank you very much, Nick, for a very interesting and comprehensive presentation, really. Well, we are a little bit behind time, but well, we can have one or two questions very quickly. So over there, please.
Thank you. Hello, I'm from Greece, actually, and I'm from Thessaly region that we have the introduction of the virus last week. It's really concerning this because in the 4 regional units of the 73 units in Greece, we have the 1/4 of the population, the sheep and goat population there, with 6,000 holdings in a very dense area. So it's really concerning, and we seem to be now losing control, actually, in Greece. And the introduction in this region is really concerning. So regarding the, we actually want to, at least in the region, to organize an active surveillance and intensified sampling scheme in order to not run behind the disease right now. Last week, the farm that was positive, it was through the report of the farmer and the private practitioner, which is not a common thing. Usually the farmers try to solve the problems on their own. They try to hide the problem because they're afraid of the whole situation. They are afraid of the social stigma. So we are really behind. The lesions were really huge on the odors of the sheep. The thing is that in the next days, thinking that the situation was around, that the virus was there at least 1 month in the area, we did active sampling with nasal swabs and whole blood samples in the farms near there. There was a bit of argument on this sampling scheme, but 2 farms were found positive, regardless of the symptoms. There were no symptoms, and we managed in the nasal swabs to find 2 positive farms. So this is my comment on the situation. I would ask you if, do you think that the active sampling scheme in these situations that you need to act really fast, going for intensified sampling in nearby farms, the density is huge. I mean, in 200 meters, you have other farms with poor biosecurity measures, we have to say. Do you think that it's really helpful? Another question is about the serological. I didn't see any data about if the serological surveillance could help to find.
Okay, thanks very much for first of all sharing this additional information. I wasn't aware, so it's already good that farmers seem to notify themselves. It's really crucial. Would I advise to do laboratory surveillance? Well, the situation from Spain has shown, and as you say yourself, it can help. You will be ahead of the outbreak 1 or 2 days. But it depends a little bit how sustainable it will be for your country. The budget-wise, also the laboratory capacity will determine. I think if that's not possible, doing a very intensive clinical surveillance with repeated visit of those farms could work also good. But if you have the capacity, yeah, I would do the testing of the swabs. And then for serology, I indeed didn't went into details about the different tests. But what I can say with the tests that are currently available, and also that we know how the humoral immune response develops in an animal, it will take several days before you get ELISA positive samples. So first they will be PCR positive. So I think if you want to really an early detection, you will go for the PCR. And if you, mostly what we see, if you find ELISA positive samples, is that you're already quite far in the outbreak and that you will run behind effects.
Thank you very much. Nick is around, so we can continue the discussions and the questions during the open session. I suggest we stop now with this session. On the screen you can see excellent posters on Capri-Pox viruses that are available and can be seen in the Reading Coffee Room. And to remind you, please vote for the best poster in the EuFMD app. Coffee break is being served close to the garden where we had the cocktail yesterday, and we will last until 11:15. After the coffee break, we will continue with session 1 on virology, fast virology, that will be in room A here, and second session on fast epidemic surveillance in room B. So please come back on time, 11:15. Thank you very much.